If I can invite Dr. Yattoo as our next speaker. Dr. Ghulam Yattoo is a professor from Srinagar, India, currently practicing as a GI consultant in the UAE. Dr. Yattoo, thank you so much for joining us at this late hour, your time, and over to you. Thank you.
Thank you very much, Dr. Neil. And at the outset, I must express my thanks to all the coalition members for inviting us to give me our experience in treating hepatitis C patients during pregnancy. You can see this now. Though it was very challenging, but finally the outcome of this study were very gratifying for all of us. The study was done in India, Kashmir, at Srinagar Institute of Medical Sciences. Well, as you know, that India harbors nearly 1/5 of the world population, and with a prevalence of HCV infection of 1 to 1.5%, it's estimated that nearly 19 million infected patients live in India. But unfortunately, only less than 5% get diagnosed. And the reason is you don't have a universal screening, and only those patients get diagnosed who are having high risk behaviors or who come for voluntary blood donations. Or in our setup, we have a universal screening before surgery, before any interventional procedures, so we can diagnose those patients, but the major chunk of patients remain undiagnosed. And you can see that there's a huge chunk which is a hidden iceberg. So in this missing millions, there is one special group, I'm sure, and that is these patients who are pregnant and are carrying HCV infection. But this hidden iceberg matters actually in reaching the elimination goals of decreasing the morbidity and mortality of Hep C, as has been declared by WHO by 2030. So if we have to achieve these goals, this hidden iceberg has to be explored. And one of the special groups in this hidden iceberg is these pregnant patients who can be treated, which we'll subsequently talk about. Now, if we talk about the history of HCV treatment, why do we say that we should treat these patients? The reason is that if we look at the history of HCV treatment, it started with interferon-based therapies, which were having very poor efficacy. They had a lot of side effects, cytopenias, fever, and there was a risk of decompensation. But once the DAs came in the game, actually the total treatment policy of the hepatitis C totally changed. And these drugs have very less adverse effects, and they are very efficacious, and the cost has substantially come down in these patients. Now, has the same evolution happened in the management of these chronic Hep C patients during pregnancy? I will say possibly yes. And though if we look at the various guidelines and whatever previous speakers also elaborated, that most of the guidelines do not recommend that any patient in pregnancy should be treated with DAEs. Now, this is despite the fact that we have some animal data that these drugs, DAEs drugs, have been found not to be embryotoxic, and many of these drugs have been declared as category B during pregnancy. Now, with the resurgence of the hepatitis C in pregnancy because of this opioid crisis, I think the incidence is increasing enormously, and most of the people now believe that possibly a call has to be taken that these patients need to be treated. And the treatment has also become imperative, and we look at the impact of this HCV infection on pregnancy. It has effects on its maternal outcome, its fetal outcome, and what previous speakers also talked about, mother-to-child transmission. And as on date, we don't have any preventive options for this mother-to-child transmission of HCV when a patient gets pregnant and having an HCV infection. It also becomes imperative that if you treat these patients, we can definitely avoid these maternal and fetal bad outcomes in these pregnant patients. Now, with these things in background, we actually had a lot of patients with pregnancy and having HCV infection, and their families, their husbands, their parents, they were quite worried, and they would approach us that for what treatment we should give, because they were worried of the mother, they were worried about the child. Now, what we did, after giving a due course of thought, we as hepatologists, then pediatricians and obstetricians, we convened a couple of meetings to discuss this issue, and we reached to a conclusion that we should conceive a study so that we can treat these patients, having some data that these some of the drugs of these DAs are category B drugs. So this study has been done at the northmost state in J&K state, Jammu and Kashmir. And in Kashmir, we have the only one tertiary care hospital with the name of Sher-e-Kashmir Institute of Medical Sciences, which has a dedicated hepatology unit, a dedicated neonatology department with a neonatal intensive care unit, and we have two maternity hospitals affiliated with it. So in the group, we had a pediatrician, we had a hepatology team, and we had the obstetrician team. So we conceived the study. It was a single center study, and over a period of 3 years, from 2016 to 2019. And our inclusion criteria were that all pregnant patients between 18 to 14 years were included who were viremic, they had positive HCV RNA, and they did not have any fetal abnormalities on ultrasound at the baseline, and informed consent was taken from all the patients. We excluded all the patients who had an HIV or HBV infection, and obviously the study was conceived after the full ethical clearance was taken from the Institute Ethical Committee. I will also mind here that before considering the study, since we did a study in a government sector, we don't have any insurance issues. So to ensure a good follow-up, and we ensure that all these patients get free testing done, free ultrasonography done, and for that a special approval was taken from the head of the institution. Now, regarding the medications, the government of India has done a commendable job that in many of the states in India, the drug supply was given free to the patients of hepatitis C, and our state was one among those states. So what we did, we decided to treat these patients with Ledipasvir combination of 90 and 400 milligram. The reason of choosing this was that this was also a category B drug, and we had earlier used this combination in a big cohort of patients of genotype 3 patients, which is the major chunk of patients in our population. So our patients in every 4 weeks and 12 weeks, and then after 12 weeks of the completion of treatment had an HCV RNA to study their rapid viral response, end of treatment response, and then the sustained viral response. Ultrasound was done almost monthly basis and at delivery for fetal malformation, and all these things were free to the patient. And every patient was monitored for various side effects, and at the delivery, the pediatrician would look any fetal abnormalities and also coupled with the ultrasonography examination. The children born to these mothers were screened for anti-HCV and HCV RNA if needed at 6 and 18 months of these patients. And our primary endpoints were to assess the sustained viral response 12 weeks after the treatment and the prevention of mother-to-child transmission. We were having 26 patients who fulfilled the eligibility criteria in our study, and these all 26 patients had same socio-economic status. They were belonging to the same religious group, same ethnicity, and there was no language barrier between patients and the treating physicians. They were all in the age group of around 28 with baseline liver functions, renal functions, coagulation parameters normal, and all the patients had a normal FibroScan, and all were viremic, and the majority of the patients had Juno 3 in our patients, which is otherwise also in our general population. And we gave the treatment. Our 15 patients received treatment in the second trimester, and 11 patients received treatment in the third trimester. And what did we found? We had the first thing is that our follow-up was absolutely fantastic, and all the patients who were treated had a rapid viral response. They had end-on treatment response, and all the 26 patients had sustained viral response. None of these patients had any intrauterine death of their child or any neonatal death, and there were no major or minor congenital abnormalities detected ultrasonographically or by any clinical examination. We had given a questionnaire to the patients wherein they would record the adverse effects of these medications. And to be honest, and we hardly found any drug adverse effects in these patients, barring a few patients who had some fatigue, headache, nausea, and there were 8 patients who did not report any adverse effects with this medication. Now, to study the mother-to-child transmission in these 26 infants born to these 26 mothers, we did their anti-HCV at 6 months and then 18 months. And what we found that 4 of 26 children had anti-HCV positive at 6 months, but HCV RNA was negative in all the 4 children. And at 26, all the patients were negative for anti-HCV. Now, these are some of the photographs of these babies which were born to these treated patients, and these children were so gratifying for us that no untoward effect has taken place with these medications, for which you don't have the ideal guidelines or recommendations from any societies. But because of the pressing compulsions from the patients, we were forced virtually to take the study, and the results are quite in front of us, and which has actually made us to continue the study. And we have gone up beyond 26 patients, and as on date, we are nearly having 40 patients who are in the process of completing their anti-HCV treatment during pregnancy without any adverse side effects. And we are lucky that recently Chappell et al. Have published a study on the same combo, and they have also found that when they treated 9 patients, they found that there were no fetal side effects, and these drugs were also safe. And they also have found that there is no need of adjusting any dosage during pregnancy and the non-pregnancy patients. To conclude, I will say that this combo of Ledipasvir and Sofosbovir combination is very well tolerated, and it has hardly any side effects, and there are very minor adverse drug reactions with this combination. Virological response is good during pregnancy, although the sample size is small, but all our 26 patients achieved SVR. There were no major or minor fetal malformations in the study group. Clinically, as well as on the ultrasonography, especially towards the cardiac defects or any limb defects, so many things were assessed, but nothing was seen in these children. No infant was infected among the studied cohort. Again, it's a small sample, but it definitely tells that this strategy of treating patients during pregnancy does prevent mother-to-child transmission. The combination seems to be safe, well tolerated, and effective for treating chronic Hep C during pregnancy. However, larger studies are needed to really give the different organizations a full quota of data, so that these recommendations are now given in all the by the guidelines, so that these pregnant patients get treated during pregnancy. Thank you very much.